All right, guys, appreciate you showing up. We're going to run through the software certification course. This is what we call our home care beginner course. You guys did not get the beautiful picture of my dogs or the quote that goes along with the actual published brochure, so I'll read it to you. You can learn new things at any time in life if you're willing to be a beginner. If you actually learn to like being a beginner, the whole world opens up to you. Okay. The reason we put that on there is because healthcare in general, home care in particular, is one industry that, regardless of how long you've been in it, it honestly is a new world year to year, and you have to think in terms of being a constant learner if you're going to really master this industry. All of you guys are operating under different reimbursement structures, under different auditing rules. OIG is looking at different things for each of you. I mean, you name it. The whole world is different day to day, specialty to specialty. We're going to walk through kind of a generic overview of how the software works for a home health agency. It'll apply to pretty much all of the provider types that we have here today. We have a second course that's the advanced course, and those are specialized per type of agency. So Medicare would have a much more in-depth training on PPS and OASIS and reimbursement strategies that go along with the Medicare PPS system. Pediatric therapy providers, same thing. Your reimbursement strategies are going to be a little different. We'd focus a lot more on working with managed care organizations, taking deductibles, copays, that type of thing. But for today, we're going to run through pretty much every part of the system so you see how it operates, and you should be able, for the most part, to fill in some of the details until you take the advanced course. And as we're going through this, some of the things I want you guys to understand, when we built the system, okay, our first priority was to make sure that you had regulatory compliance for financial reimbursement. Okay, and it's a long sentence. There's a lot of caveats built into that. But if you're going to understand the system, you have to understand that purpose, the purpose behind that sentence. Okay, we get a lot of calls, right, where people say, well, or if we like conduct a sales demonstration, where people say, we just had a state survey and we were deficiency free. We never have deficiencies. It's one of the things we pride ourselves on, which is fantastic, right? It's really good. I don't want to minimize or degrade that in any way. That's fantastic. But the reality is a state survey is not what's going to put you out of business, right? OIG, the Office of the Inspector General, coming in, auditing your financial records or your clinical records as they pertain to what you build, those are the types of investigations or problems that can very quickly put you out of business, even when you haven't done much wrong. Okay, we've seen state surveyors walk in and true story, situations where administrators were most likely completely high on drugs, who kicked the surveyor out of their office, still in business, okay? Because the way state surveys work, they're not designed to put you out of business. They're designed to catch clinical deficiencies, coordination of care deficiencies, but you have a chance to make those corrections, right? As long as you have a strong enough plan of correction, you're only having to correct the previous 45 or 60 days, and that's all they're going to audit when they come back in to do a follow-up survey, right? You may be out a few $1,000s in fees or penalties for the resurvey, but it's very difficult to be put out of business, right? Even if you're put on fast track, there's still a number of scenarios where you're able to stay in business and continue operating without any loss of significant financial resources. But the fact is, if OIG or MFUCU, the Medicaid Fraud Control Unit, the FBI, God forbid, or a number of other federal and state agencies that are designed to catch home care or healthcare fraud and abuse, when they get involved, even when you've done everything right, or most things right, the ramifications are really, really difficult. Just a month or two ago, I got on the phone with an administrative law judge. When you're audited by somebody like OIG, okay, they'll send you a letter. They'll say, send us these 30 records, right? This sample of records. In our case, it was around 40 records for this agency I was defending. Around 40 records. OIG takes 8 or 9 months. This not OIG, but this is the actual the first level investigation. It takes 8 or 9 months to go through their investigation. Immediately, then they send a letter that says, okay, out of 40 records that we've audited, we found 30 of those that this is a Medicare agency where the patient either wasn't homebound or you didn't document homebound status or justify medical necessity to the point that it qualified for Medicare reimbursement. So that's 75% of your records that we audited that don't qualify for Medicare reimbursement. Therefore, we're going to assume that out of the entire 3-year period that we sampled from, which was several thousand records, we're going to assume that 75% of all of those records don't meet Medicare reimbursement guidelines. So now you owe us back multiple millions of dollars, and we expect the check within the next 30 days. That's the difference between a financial investigation, a fraud and abuse investigation, versus what we traditionally think of in like a state survey realm, okay? Fast forward that case, we go through the appeal process, the reconsideration process. This goes on for 18 months. At one stage, we get about half of those records overturned. So we're down to 19 records, and they're still asking for multiple millions of dollars back, even though we disproved without ever speaking to someone, just on a paper appeal, we disproved half of their audits, right? We proved that half their audits were incorrectly done, and yet they didn't drop the case, they didn't walk away, they actually increased the amount of penalties that were due, even while deducting some of the claims that they had counted into their audit sample, okay? 18 months later, we finally get in front of an ALJ. And when I say in front of an ALJ, I actually mean that there's a retired judge who sits in Florida in a high-rise, and we get to talk on the phone and defend our case, right? And so you're basically calling witnesses over the phone, introducing them to the judge, trying to explain what went into the record. Out of those 19, we were able to display that multiple of those were being audited according to the wrong standards. It was 2010 records that were being held up because the physician used a stamped signature, which wasn't put into a policy manual until 2011. Issues like that you know, any rudimentary glance at the record should have shown was incorrect. And it still took 18 months, and we're still waiting on the decision from the ALJ. Okay, during that 18 months, for about the past year, that agency's not been reimbursed by the Medicare program. Right? Very few agencies would be able to stay in business in that through that type of length of investigation, that type of reimbursement hold. And this is an agency whose clinical care state deficiencies have always been zero. Right, documentation is very good compared to your standard home health agency, right? But the things that weren't being coordinated in their medical record are the things that ended up getting them into trouble that we had to piece together. So in a traditional audit, we have to go through and say, okay, Medicare requires homebound, and it requires homebound status to be documented in one of 3 ways. And we would have to go through the record and kind of pick out and make a case. The way our system has been designed is to make that case for you when someone looks at your record. Okay, for instance, if you look at our Medicare admission documents, there's a homebound questionnaire as one of the categories. Traditional home care documentation simply says, why is the patient homebound, or what's the homebound justification, with a few checkbox options, right? Ours is a long questionnaire that we ask that you fill out when you do the admission and every recert, because that proves or really gives you a lot of justification for the primary denial reason for Medicare, which is lack of homebound status. And so that sets you up with a really good homebound status right off the bat. And then every routine visit, traditional home care documentation has that exact same question box every time. So in your admission, what's homebound justification? You have a few check boxes. The next visit, what's homebound justification? You have a few check boxes. Well, what ends up happening with those is, number one, you didn't document homebound very well at all. You didn't justify it. And on the second visit, if you check any of those other boxes, now you've undermined the homebound justification you created on your first visit. So what we do is, on our very first assessment and each recert, we give you that long questionnaire. At each visit thereafter, we simply ask you, has the patient's homebound status changed since the previous visit? Right, so the default would be no, and you're keeping track of that. So you've justified homebound status really well up front for the episode, and then you don't undermine it throughout the episode. Okay, that's one example, but I wanted to bring that to your attention because it's really what drives everything else that we do in the system, right? It's designed around, first, justifying your financial security whenever you bill a claim out of the system. We want to make sure that every piece before that is tied together in such a way that when you print out that document, or when an auditor looks at the system, it justifies the things that they're going to be looking at right off the bat. Okay, so today we'll talk through kind of the compliance standards, how we assign out duties amongst your different job roles. Then on a profit side, how we would manage reimbursement strategies, setting up pricing structures and things in the system. And then on the growth side, how you can better recruit, better market, do better brand management. That's really the way the system is scaled to work. All right? There's the foundation. As we move forward, again, beginner level course, we're just going to kind of walk you guys through the processes of running a home health agency in the system. Definitely look for the advanced courses that we'll be offering hopefully later this year. Anyway, aside from that, let's jump in and get started. I know you guys have all been in the system, so we won't waste a lot of time there. Lindsay's going to be steering us through the demonstration. We're in a test database, so we'll see what happens. You first log in. It's going to take you to a dashboard screen. This is designed really just to mimic your day-to-day workflow. So if you're a nurse, you log in, your point of care schedule should be available for you right there. Any messages or tasks that you have, you should be notified about there on your home screen. And then across the top, the way we've set up the menu system is really designed to mimic the process flow of what we would expect to happen day to day in a home health agency. Okay, before we can really walk through the day-to-day process, though, we're going to walk through the initial setup of the system. Okay, and this is where I see probably most of our agencies having problems, is that they don't understand really the setup or design of the system, and it ends up causing problems later on. So let's look first at kind of setting up our administrator account. Whenever you guys logged into the system, you have at least one person who is assigned as your administrator, the owner of the data that goes into the system. That's all available to you from under your administration tab. We have a couple of things. First, let's start into our, let's go ahead and go to the company settings screen. These are the global settings that affect how your agency's system works, okay? As far as your contract with Good Looking or HealthTrust, the way we identify who we're allowed to speak to and work with at your agency is based upon the fields that are listed out here, okay? Company type, all of you guys should be set up as a home health agency. then we need your administrator, billing contact, clinical contact listed out in those fields. That's who we're going to call if we notice any type of problem with your account. Who we're allowed to work with, IT contact, obviously phone, company fax, your company logo. If you guys work with any of our customized forms, there'll be some things I mention in passing that we won't have time to delve into, but just know that you do have the ability on your marketing side to create customized 485s, plans of care, verbal orders, medication profiles, et cetera, that would have your company logo on them. That would kind of help out with some marketing pieces. Other places in the system like our online job applications, physician portal, where we can use your company logo. That's available here in our company settings. Default county, where most of your patients or where you want your default patients to reside. While we're here, let me just make one mention of how the system works. We do have a company setting, which is global for everything that you do in the system. Okay. But we also have a provider or office level. So for those of you who run multiple locations or multiple provider types. So if you have a private duty nursing agency and a pediatric therapy division, you'll probably have those set up under two different provider settings within our system. And so you have a company level that controls some things, and you can override those at an individual office or provider level. So when we're looking here, default county for your company where most of your patients will reside, default time zone, I believe most of you guys are here in Texas, so central time zone there. And then just a list of documentation settings. We won't run through each of those because it's not that big of a deal, but this is, if you've ever wondered how the system automatically generates your certification periods or your episodes, what dates that it's going to use. If you wanted, like for pediatric therapy, if you wanted a 6-month certification period rather than the default 60 days, all of that's controlled here from our company settings. Okay. If you'll scroll up, you'll see another tab that actually has components on it, and this controls what components are available to you in the system, whether you want to have a hospice plan of care, or if you use the Medicaid plan of care, what type of agent licensing screen you want to use, what billing version. One of the things you'll see as we update the software, we're trying more and more to leave the software as is and allow you guys simply to turn on new features. This is where you would be able to do that. So like with our billing, you'd be able to go in and just simply select the billing module version that you want to use, so you can take advantage of the newer features that come out. The last tab on that screen, or the third tab, would be your company holidays. When you're running payroll through our system, you will need to set up your holidays so we know when holiday pay would go into effect. And then terminology. By default, our system has terminology where we say that, again, we have a company level and we have what we call provider level. For pediatric therapy companies, a provider, their terminology typically would be the employee, right? So provider can be a little misleading, so you can change that in here to office or branch or location. Same thing with patient, agent. Some people want to call those employees or contractors. The reason we use agent by default is because a lot of times you're not hiring an actual employee. If it's a contractor, we want to make sure that you have that distinction in your system so that there's a clear delineation between contractors and your actual employees. Same thing with episode. We default to the Medicare terminology of episode. Pediatric companies, you may prefer cert period to be put in there. Again, that'll just simply change the way we label documents within the system. And then these agents 1 through 6, we'll show you where that goes here in just a little bit, but on your patient screen, you're able to allocate or assign some of your employees to work with that particular patient. We just simply label them agent 1 through 6, but you can go in and change those. So if you have designated translators, or if you have designated social workers, or schedulers, case managers, you can control all of that, the terminology right here on your company settings. Okay. So that's your first level. I'm going to go ahead and skip around real quick and jump over to our reference files and down to what we call providers. Again, some of you may call that an office. This would be your, again, individual offices or divisions within your company if you want to keep those separated. Okay, the one caveat here that you need to think about when setting up your system is that a provider or office, a patient can only be attached to one office. Okay, so if a patient is seen by both your private duty nursing company and your pediatric therapy division, you would have to create two different patient accounts in order to schedule and bill under each of those different entities. Okay, so that's really the only caveat there. But for the most part, we like to split out different operations under different provider types. Go ahead and click on one of those, Lindsay. And the way our providers are set up, you will see we use the field code on most of our screens. That's an internal identifier that for the most part you create. Under company settings, you do have the option for us to create your employee code and your patient code or MR number. But for everything else, you would simply type in a code that allows you to identify that particular record. As an aside, most of the time, don't simply brush past codes, categories, because when you're setting the system up, your forethought and how you're going to use those codes can make a lot of productivity gains occur. So for instance, when we set up codes or we set up categories, we generally try to start with the most generic category identifier on the left-hand side. Give you a good example that comes up a lot, supplies, right? You have the ability to put a code on your supplies. Probably the easiest way to do that is under supplies. I would set my code to be the body system or the category that we're looking at. So if we're dealing with nebulizers, right, I wouldn't put my code in as the actual like model number of the device. I would put NEB, or I may even start it out with respiratory, RESP-NEB/001. Okay, so that all of those are categorized in the same area. When you run reports, you could run a report for codes that have RESP in the code, right? It gives you another layer of organization and reporting. Name, address, city, state, zip, region. If you, as you guys grow larger companies, you may want to actually set up regions of the country or regions within your company that this particular provider falls into. Phone, fax, email, etc. All that's pretty standard. Identification numbers, NPI number is going to go on your claims, so make sure that's correct. Medicare, Medicaid number, these are all of your legacy numbers that we can use to as necessary. Scroll down. Just to let you know, accept assignment, signature on file, those are generally always yes, simply meaning by default you do accept responsibility for all of the payments that come in when you bill for a particular patient, and that you do have signature on file with the payer sources that you're going to be billing to. You're the type of provider for this particular location. And this controls some of the functionality within the system, so you want to make sure that's correct. If that provider is primarily Medicare PPS, pediatric therapy, private duty nursing, again, these will turn on or off different settings based upon the actual provider type. You can override your company's default county based upon this particular office's location. Referral alert, just mention that one. Whenever you add a new patient or a new referral to the system, it's often beneficial for other people at your agency to be notified, maybe a case manager, maybe a scheduler, a supervisor. All you have to do is simply select who you want to receive a message. Every time a new referral that's assigned to that particular provider, When they're entered into the system, we will send out a message to whoever is selected on this list. You can set up vital sign parameters policy-wide for that particular provider. What this will implement is in our point of care system by default. Until we have patient-specific parameters, we will default to your policy parameter. So when you conduct an admit visit, if vitals are outside of parameters, per company policy, we'll automatically notify you of those. And then if you do have a parent corporation that should receive payment for any of the claims that are billed on behalf of that particular office, set up right there under your pay-to provider information. Okay. Payroll and GL information we won't spend time on, but just know if you have advanced accounting, so if you need to export to like an ADP or to some type of general ledger system, we can allocate some numbers into your export file as needed, and this is part of where that would get set up at. For Medicare agencies, the setup of your OASIS information is available there. All right, now to the good stuff that we all need to be aware of, things that affect how your billing is set up. Primarily, number one is going to be the service codes that you offer. Okay, so this will be under reference and services. Services will be any supply or service that you render to a patient. Okay. Most of you, so for pediatric therapy, you would be looking at, for a particular discipline, your service may be the evaluation visit, your routine visits, your discharge visit. Here in the state of Texas, or most states, you may need what we call an interim evaluation. So if every 30 days you need to do a reassessment, we would generally set that up as a service code as well. We also generally set up non-billable supervisory visits as services. Okay, you'd want one of those for each of your disciplines. For private duty nursing, you're generally going to have your evaluation visit. You may also have an evaluation visit that's designated for when it's done in the hospital, when you're not in the home yet, so kind of a pre-evaluation visit. Obviously your shift notes, and that's generally going to be allocated, one for LVNs, LPNs, and one for RNs, because you have different payment and reimbursement structures for each of those. And then here in the state of Texas and several other states, we would also allocate when each of those shifts are going to be high-tech. If you receive additional reimbursement whenever you're handling a child who has high technology needs, we would want that as a service code. We would also generally want what we call shared care visits for PDN. So if you have one nurse who sits with 2 kids or with 3 kids, you'd want that set up as a service code. Obviously the same with discharge visits, we would allocate that out. Medicare, your admission visit, your recertification, your resumption of care, your routine visits, your discharge visits, each of those would be set up as a service code. Lindsay, let's go ahead and add a service code in just so we see what that process looks like. Just click on Add Service. You'll tell us whether it's a service or a supply. For the most part, most of our agencies are not billing for supplies, so there's a distinction in that process. But if you click on supply, it's pretty obvious how that's filled out. For Medicare agencies, we would just attach those supplies to your final claim under the one service line item for supplies, and we aggregate the cost according to what you put into the cost field for the supply. Tell us whether it's routine or non-routine. That allows us to track not just your cost and your Medicare cost report information, but it also allows us to help with inventory, profit and loss on an episode basis, because you do get a supply utilization payment for Medicare, and we would be able to kind of tell you whether you're making or losing money on supply utilization. Okay, same thing on all the other types of visits as well, or types of agencies. We can help with inventory as well as profit and loss reporting. The services, though, are obviously by far the most important that we're dealing with, because those are the ones that you actually get paid for. So again, we would set up a code. Again, generically, we would like to start with the category of service. So if we render PDN and pediatric therapy, I would start with PDN or PD as the beginning of the nomenclature there. So maybe PDN-eval, PDN-shift-LVN, PDN-shift-RN. Under the description, you just type in what you want to print out on the top of your visit notes. Okay. Your code and your description are going to show up at the time that you're scheduling. Okay, so these serve two purposes. One, the code should help your scheduler schedule as quickly as possible, which is why we categorize them the way we do. If you go into some systems where there's not a lot of forethought in the way service codes are set up, you'll see some codes that are put in under RN and some that are put in under SN, right? So as a scheduler, when you're going through, you kind of have to read through that whole list to find out, right, what I want to schedule. When it's planned out really well, it becomes really obvious. I can scroll through my PDN shifts, I can scroll through my pediatric therapy, I can scroll through my Medicare visits. So even in some of our demo databases where we have all types of home health agencies, scheduling becomes very easy. Even when we have 50 different services to go through, it's very easy to see which category I'm in at the very beginning. Description, like I said, will show up on your schedule, but more importantly, it does show up on your hard copy printouts for your visit notes. Okay, that becomes important really at the pediatric therapy level and at your if you're doing even adult therapy, but especially pediatric therapy. Okay. Because the one difference with pediatric therapy that's different than Medicare or private duty nursing is that we don't create a separate plan of care document for you. Okay, we assume that your physical therapy evaluation is not only the evaluation, but it also serves as your therapy plan of care. We still have to meet state standards, and if you're licensed and certified, obviously CMS standards. But the state, even at the state level here in Texas, you have to have a plan of care, and your plan of care has to have certain elements on it. You'll see that as part of our therapy evaluation. It's why we ask the same questions on your PT, OT, and ST evaluations as far as safety measures, a pain assessment, hazards in the home, health history, etc., because we expect that document to stand as the plan of care. That's important here because for pediatric therapy, we always would like to put for our evaluation something like pediatric physical therapy evaluation / plan of care. So when this prints out, when you're sending it to the doctor, if an auditor is reviewing this particular document, it's very obvious at the beginning that this is serving as your plan of care, and they're not expecting like a 485 or a separate plan of care document. All right, categories. These you actually do control. They can be set up on that first menu. You can control your service categories. For the most part, these are going to be, we recommend SN, PT, OT, ST, PDN. Right, you can break those out a little bit more if you would like to, but for the most part, those standard disciplines work really well. This gives you a way, again, of categorizing your services, but also for reporting purposes. So if you wanted to see all of your profit and loss for physical therapy, this would combine on a report evals, routine visits, discharge visits, reassessments, etc., and you can run them all at once. If you're running payroll through our system, then we want to know whether this type of visit counts toward your maximum hours, meaning you can tell us at the agent level how many hours a week that employee is able to work. Some types of visits we don't want to count, even though they're a service, we don't count them on our schedule toward their total work hours. Maybe like a non-billable soup visit, possibly a training visit, orientation that you'd want to set up potentially as a service code. Whether we want to include this in payroll or not, you have some options for allocating this out to your payroll departments on the exports. Again, that's a little more advanced, so we won't get into that, but just know that as you need payroll exports out of the system, you have a lot of options for controlling what that looks like. Payroll points, if you want to, a lot of agencies will, rather than calculating money, they'll effectively say, for a therapist, you're going to get this salary, but we expect that you'll work 20 points a week. So an evaluation visit may be worth 2 points, a routine visit may be worth 1 point. This is how you would control that. You could say an evaluation visit is worth 2 points. When you run your payroll reports or your charge reports, it's very easy then to allocate or add up those numbers. Type of record, possibly one of the most important fields on this particular screen. Now, you may have 50 different services in the software. The type of document controls the documentation form that's getting filled out in point of care, and there are a limited number of those. Okay, so for private duty nursing, we have 3 different evaluation types. We have 2 different, depending on your company, we have 1 or 2 different shift visit notes. For Medicare nursing, you'll see a lot of OASIS visits. For pediatric therapy, you'll see those all listed out here as well. So you would choose the form that is most appropriate for that particular service. A couple of caveats there that I know a lot of agencies run into. Pediatric therapy, when you're conducting what we would call our interim reevaluations, like the 30-day reassessments, where you're not required to do a full reassessment, but you need a little bit more beefier documentation, we would generally still recommend just using a routine pediatric therapy note for that, but labeling your service as physical therapy reassessment or interim reevaluation. Discharge visits for most disciplines, obviously other than Medicare has its own discharge OASIS form, but most other disciplines, the actual discharge visit would be the same as your routine note. You would just select that it's a discharge visit, and you would have a discharge summary form that's available on that routine note, but the rest of the documentation is exactly the same. Documentation header, you'll see this here and on the patient screen, and they work in conjunction with each other. Texas Medicaid providers are required to have the patient's Medicaid number and date of birth on all documentation. There are times when you may need documentation, like, perfect example, MDCP in the state of Texas requires extra documentation along the top of the screen. We have clients all over the country, so we don't set up by default those types of that type of information on a visit by visit basis. So if you need something to always print at the top of a visit note, you would want to fill it out either here at the service level, meaning every skilled nursing visit we print needs to have this information put at the top of it, or at the patient level. So if you need the patient's Medicaid number and date of birth on all documents on the patient screen, make sure you put their Medicaid number and date of birth in the documentation header field. All right, limit to provider allows you to obviously only see the service code when a patient belongs to a certain branch office. All right, and then we have pricing, which would allow you to actually set up billing information for this particular service code. We'll walk through that here in just a second. We'll do that from the patient screen, but just know that if we set up a PDN evaluation visit, we're going to bill that visit differently if we're billing Texas Medicaid versus Arizona Medicaid versus Blue Cross Blue Shield or versus Superior, right? All of those are going to have different HCPCS codes, revenue codes, modifiers, billing structures all together. And so we'll walk through how to do that here in just a second. You can do that from the service code screen or from the payer screen. All right, so let's go ahead and go to look at our payer setup under reference payers. The insurance companies that will be responsible for paying our claims. Let's just look at Aetna real quick. Again, same type of thing. Code, just be smart with the way that you set your codes up. Name, address, contact person that you're going to be speaking to at the insurance company, phone number, extension, website. If you put a website in there, when we go to our collection screen later on as part of our financial collection process, or if you check eligibility by calling them on the phone or looking up their website, if you put their phone number and an actual website in, then we'll be able to link you directly to their website or pull up the phone number for you at the time that you're checking eligibility or performing collection activity. If it's a website and you log into their website as a provider, you can put in your username and password there. That will show up at the time that we're doing collections as well, just to make life a little easier. Tell us how to check availability for this particular insurance company, where you can run a eligibility file that'll get dropped off to CMS and returned back into the system. TMHP, you can click a button, will take you directly to the TexMedConnect website. Availity, some of the other clearinghouses, we're actually working on direct connections for checking eligibility and claim status with those guys. Phone, fax, website would actually just pull up either the website or the phone number for you. The rest of this is all fairly standard. Line of business, the category for the payer, again, just like with your service codes, you would want to set up your categories in a way that reflects your financial reporting. So if you wanted to see how much money you made for all of your Medicaid or your Medicaid managed care organizations, you probably want a category for Medicaid and another category for Medicaid managed care, one for commercial, one for self-pay. And then, of course, you can turn it on or off by setting it to active or not. Let's go set up some service pricing now. So when we go to, actually, let's go back to claims, the claim screen real quick. This controls how we're able to bill for this particular payer. One, what claim form are we going to use, whether that's the UB04 or the 1500, or PPS claims are slightly different. They do technically go on a UB04 claim if they're hard copy, but because it's a wrap final claim situation, we treat those differently, so you'd select PPS there. Self-pay would go on a self-pay invoice. You can tell us if you don't want us billing this claims to this payer electronically. By default, we assume we're going to bill everyone electronically. Use service-specific primary diagnosis code. This is very beneficial for pediatric therapy companies. By default, when we bill a claim, we're going to use the 10 diagnosis codes that are on the patient screen that are assigned to your patient profile, unless it's a Medicare or a PPS type claim. If it's a PPS type claim, then we're going to use the 10 diagnosis codes that come off of the plan of care for that particular episode, okay? The third way we override the diagnosis code that gets sent on a claim is by checking that box there. And if that is checked, I'll show you in a minute, on the patient screen, you have the ability of setting up service category specific diagnosis codes and physicians. So if you have, for one patient, let's say pediatric, PT, OT, and ST, we want the primary diagnosis on each of those claims to reflect the discipline that we're billing. We would want a speech code on a speech claim. We would want some type of PT code on a PT claim. And so we look at all 10 diagnosis codes that are on the patient screen. But for the primary diagnosis, we can pull the diagnosis code that comes off of the services tab at the patient level so that it is service specific or discipline specific. Default type of bill, claim indicator, all of those are just standard billing nomenclature fields. How we're going to submit your electronic claims. Hopefully you guys are all set up with a clearinghouse for all of your commercial or non-Medicare claims, so we can send those directly out of the system and receive the responses directly in the system. So those are set up here. And then how you want us to bill hard copy claims, because of course every insurance company has their own requirements. You're able to override some of those fields with the settings that are available here. And then under requirements, these fields control what we're actually going to do on your claim. If they require a primary physician, then if the patient doesn't have a primary physician, we're going to give you an error when you're trying to bill that claim. Down toward the bottom, you have some options for how you want us to group those claims. So if you're billing hospice or private duty nursing, where we need to group all of your charges together for the same day in the same HCPCS code, you want to make sure that we're billing those and grouping those by, generally by date of service, because a date of service will also automatically take into account HCPCS code and revenue code. So if you have an LVN visit and an RN visit on the same day, you would have 2 line items. But if you had 2 RN visits on the same day for the same payer, same patient, then we would group those together under that one line item and just add up the quantities and the billing amounts. Really beneficial, like I said, for PDN, where if you have 2 or 3 shifts on the same day, you need to make sure all 3 of those are confirmed and billed at the same time. Otherwise, your insurance company is generally going to deny the second claim as a duplicate. These are the types of fields that control those settings, right? How you want us to group those charges by date of service, how often you want us to bill those claims. By default, we try to bill everything that can be billed as quickly as possible. This is a difference between what we expect to happen and what traditional home health kind of teaches. Most home health teaches we have one day of the week where we're going to bill all of our claims. We want you to be able to bill just as soon as possible. And so individually is generally the option that we're going to go with. There are times, however, we need to group claims together by day or by week. And that would effectively, what would happen there is the system is going to make sure that all of those charges within that time frame are ready to be billed, or it's going to warn you that you're missing visits within that time frame. All right, from a collections perspective, these 2 fields right here are really nice. Timely filing deadline and payment floor. Timely filing deadline allows us to warn you whenever you're getting close to not getting paid because you haven't billed a claim yet, right? Generally that's, you make sure that's set against a per payer level setting. So Blue Cross has a 35-day timely filing limit. Make sure that you have that selected. On your billing dashboard, we'll notify you, right? You have 7 days left to bill out this particular charge, or you're going to miss your timely filing deadline. Your payment floor is a little bit more vague, but it does help us project your cash flow. Okay, so for Texas Medicaid, you're generally getting paid every week. So you would set your payment floor to 7 days. For Medicare, you may set that to 14 days, depending upon your payer. This is how, on average, how quickly you're getting paid from the day that you bill. So what we can do there is actually project out your cash flow on a day-by-day or week-by-week basis. Okay. A couple of other settings, again, that are really just dependent upon the payer and how picky they are whenever you're billing a claim. Whether we need to include the HIPS code on the UB04. Again, different payers have different settings, so you can control that here. All right, now let's look at the services that are available for this particular payer. Okay, by default, we bill or allow you to bill any payer for any service, and we will use the default price for that service. You have the ability then to override the default pricing rate on a per payer or per patient basis. All right, so if we're looking at Aetna, we have a list of all of our service codes here. We tell you what the default price is or what it's currently set. So if we bill Aetna right now for a speech therapy evaluation / reevaluation, we're going to bill at $175. If you click that update button to the right, this shows you what we're billing, okay? We can tell quickly that we haven't set up anything specific for Aetna for this type of service because it says add service price. If that said edit service price, then we would know that we've already put one in for Aetna for this service type. So this is our default pricing that we would bill for every payer unless we set up an override. So let's say for Aetna, we want to bill this with a 92507 CPT code. Okay, revenue code, somebody just made that one up. This would generally be 0441. You have to have 4 digits, so for those of you who are used to billing, generally you're going to add a 0 to those the revenue codes. If you have any modifiers that you need to add, the charge amount, how much we're going to bill to Aetna for this particular type of visit, and whether we're going to bill that on a per visit or per unit basis. Okay, if we say that we're going to charge this amount per visit, then regardless of how long that visit is, whether it's 15 minutes or 5 hours, we're going to bill $175. If you say that it's per unit, then we would multiply the 175 by whatever measurement that you set up below. That's going to be set up under the calculate billing quantity as 1 equals, okay, either 1 visit, meaning regardless of how long we're in the home, it's going to bill just a unit of 1. Whether that's 15-minute increments, and you can also tell us how you want that rounded, hour increments down to the 10th, the 100, or the 15-minute. Lucky for us that are here in Texas, Texas Medicaid actually utilizes all 3 of those depending upon which program you're billing. So you just choose which particular service price you want to use. Very rarely you may need to use the cap quantity or override quantity. Those are available now. That's a recent feature. If you have payer contracts that tell you to always bill with a quantity of 4 or never bill more than a quantity of 6, you can set both of those fields, and we would either always, if you say cap quantity, then regardless of the number of units, once you reach that ceiling, then we'll stop calculating quantities. Override quantity as, if you fill that in, then we're always going to bill with that quantity. Again, it's pretty rare. If you have something like that set up, I would question your contracting arrangements with your payers. But there are situations where payers are pretty stubborn. They'll say, here's our contract, always bill us with a quantity of 2 or a quantity of 4. That's what that's available for. And then your reimbursement amount. If you set that up, what will happen is the system, when you bill, we will automatically write off as a contractual adjustment the difference between that amount and what we bill. And again, that's in dollars or in percentages of the total billed. So if we bill $200 and you have that set as $120 as your reimbursement amount, we'll automatically write off $80 in your ledger. That's beneficial so that your ledger always reflects a true AR statement, right? Cash that should be coming in. It's beneficial in that regard. It's also beneficial because as you're posting payments, if you're posting a payment that's different than the outstanding balance of the claim, then you immediately know that your payer did not pay according to your contracted rates. All right, so it's a very quick double check And then the third benefit is that when you go to renegotiate your contracts with your payers, we can help you pull reports that will compare what your reimbursement rate was under contract with your payer compared to what they actually paid you compared to your actual profit and loss on each of those services. So it gives you some really good ammunition when you're trying to contract or renegotiate rates with your payers. Tell us whether this particular service requires prior authorization. If you say that it does, then we're going to warn you at the time of scheduling and at the time of billing that you need a prior authorization. Whether an order is required or not, again, same thing. And then how you want us to limit this service price. So when you click there, by default, we put in who the payer is. So this particular service price is only going to be billed when we're billing the ST eval, re-eval for Aetna. If you have negotiated contract rates with a patient, you can select your patient there, and then this service price would only go into effect when we're billing that patient. You can use both of those in tandem, and we would only bill that service price when we're billing that patient for that insurance company. So it gives you quite a bit of power, and then of course you have the ability to activate or inactivate that particular service price for a period of time. So every year as you renegotiate your rates, you would go in and discontinue this rate, put in the from through date when it was active, put in another service price for the new date range, your new contract year, and depending upon the dates of service on a claim, we'll know which service price to bill with and what to reimburse at. All right, so we saw payroll settings throughout the system. You saw those in a few places. Again, that's applicable if you're going to run payroll exports like to an ADP program or some other payroll processor at your company level, at your provider level, at your service level, and at your agent or employee level. We have different payroll settings. All of those control how that payroll export is going to be controlled. I mention that simply because if you do run those exports, you'll need to know and work with our team to kind of show you how to put those into the system. We won't get into that today because it's very unique per agency. Pretty much every agency we work with has a different type of nomenclature that can be used, but the system is very flexible to generate exactly what you need. I do recommend that you guys run your payroll exports out of the system for a number of reasons. One, because it really helps calculate overtime, holiday pay, shift differential, bonuses, etc. But it also then, once that's run, we have the ability to track profit and loss, right? Which we really can't do without having your payroll numbers in the software. So I've kind of just make that distinction or notice so that you guys know that if you're not using that feature, it's definitely beneficial in a number of areas, and it's not difficult at all. It's a fairly straightforward process. We'll walk through some of that here in just a little bit.